GM is a 6-day-old female born at 39 weeks to a G2P1 mother via repeat cesarean section with postnatal diagnosis of coarctation of the aorta. This patient received an echo at birth because her sibling has a history of congenital heart defect. After the coarc was diagnosed, she was started on prostaglandin infusion and transferred here from an outside hospital. She is now post-op day 1 following left thoracotomy with end anastomosis of coarctation of the aorta and ligation of her PDA. There were no complications during surgery, and overnight her respiratory support was weaned and she tolerated coming off of dobutamine. There were no other acute events overnight. For vitals, her weight is 3.5 kilos. She's remained normothermic with a last temperature of 36.8. Her heart rates have been 110s to 130s, respiratory rates in the 40s. Blood pressures by cuff and by A-line have been 70s to 80s over 30s to 40s with max in the 50s. Her CVPs have ranged from 5 to 7, and her oxygen saturation has been 99 to 100%. On the last 24 hours, she had 421 in, 536 out for a fluid balance of negative 114. Her urine output in the last 24 hours has been 516, which is 6.14 mils per kg per hour. Upon a physical assessment, she was awake with assessment, otherwise asleep. She's receiving a continuous fentanyl drip and in no apparent distress from a respiratory perspective. She's on 2 liters nasal cannula at 50% FiO2. Her lungs were clear to auscultation bilaterally. She had good aeration. There was no work of breathing. CV, she was warm, dry, well perfused. Her cap refill is less than 2 seconds. Her heart rate was a regular, normal rate, good pulses in all extremities with no murmur. And she has a chest tube in place draining serosanguinous fluid on the left chest. FENGI, her abdomen soft, non-tender, non-distended with hypoactive bowel sounds, and she's currently receiving TPN and also has a nasogastric tube that is clamped. GU, she has normal external female genitalia, and she has a Foley in place, draining clear light yellow urine. Neurologically, her fontanelle is soft and flat. She moved all of her extremities well, and her pupils were equal, reactive, and responsive to light. Her skin's pink, she has no rash, and she has her left thoracotomy with Dermabond that's clean, dry, intact. For lines, drains, and tubes, she has a right arterial cut down A-line that was inserted in the operating room yesterday. We're using that for frequent blood draws and blood pressure monitoring. She's got a right triple lumen femoral central venous catheter that's been in place for 3 days. We're using that for administering her fluids, TPN, and for blood draws. And then she has the left chest tube that was also inserted in the OR. It has drained 6 mLs of serosanguinous fluid in the last 24 hours. And then she has a 6 French Foley urinary catheter that was also placed in the operating room yesterday. Her medications are continuous TPN with famotidine running at 10 mLs an hour. She's receiving intralipids at 2.3 mLs an hour. Her fentanyl is running continuously at 0.3 mics per kilo per hour. She receives daily furosemide 4 milligrams IV, and she's on perioperative prophylactic antibiotics, cefazolin. It's 105 milligrams, Q8 hours. Her last arterial gas was normal with a pH of 7.44, CO2 of 48. Her PO2 was 171, and her bicarb was 33. For her metabolic labs, she had a sodium of 139, potassium 37, chloride 102, carbon dioxide 30. Her glucose was 135. The BUN and creatinine of 16 and 0.38. Calcium was 8.6. Total bili 13.3. AST 47, ALT 13, and ALK Phos was 148. Her total protein was 4.9, and albumin was 2.7. Her last CBC, her white count was 28 with a hemoglobin and hematocrit of 12 and 34.5. Platelets were 286. Her chest x-ray overnight was unremarkable, showed a left chest tube and no pneumo. For her problem list, we have health maintenance. She's status post repair of coarctation of the aorta and status post ligation of her PDA. She has some post-operative pain that we're managing with her fentanyl drip and no other problems. For my impression, this baby is a 6-day-old female who is now post-op day 1 following left thoracotomy with end-to-end anastomosis of coarctation of the aorta and ligation of her PDA. She is currently hemodynamically stable and recovering as expected from her procedure. ICU admission is recommended for continued close monitoring. For our plan, from a cardiovascular perspective, we'll continue to monitor her on telemetry and monitor for the development of hypertension. We'll get Q-day 4-point blood pressures as well. From a respiratory perspective, we can wean her nasal cannula as tolerated to room air. So we'll go to 1 liter now and then off later in the afternoon if she allows us. We'll obtain Q12-hour arterial blood gases and lactates, and then any as needed if her clinical status were to change. We can keep her left chest tube in place and monitor output, and then monitor for signs of respiratory distress. From an FEN GI perspective, we'll continue her on maintenance fluids at 100 mils per kg per day, which will be her TPN. We'll get Q12-hour basic metabolic panels to monitor her electrolyte status. We can discontinue her urinary catheter, but still maintain strict I's and O's, and then continue her on her 4 milligrams daily of Lasix. She will stay NPO for now, but we will start feeds continuously through her NG tube this afternoon at 3 p.m. We'll start at 3 mLs an hour with breast milk and then increase from there. And then we can also consult speech therapy. Her last Billy was 13.3, so we'll do a repeat Billy in the morning. From a heme perspective, just monitor for signs of oozing and bleeding and monitor her hemoglobins on her Q12 ABGs. From an ID perspective, she'll continue on ANSEF for 48 hours post-op. From a neurological perspective, for now we'll continue on the 0.3 mics per kilo per hour for pain management, and then discontinue once she's tolerating feeds. We can start high set. We'll consult pain team for help with managing her pain. For discharge planning, she'll need a car seat challenge, so we'll encourage parents to bring in a car seat as soon as they're able to, and then continue to educate parents on newborn cares and medications that she's receiving. For disposition, we'll plan to keep her at least 1 more night in the ICU for postoperative care and management.